Hello, everybody. Welcome back. As she said, my name is Amber. I want to thank everybody for coming today. I want to thank the DLCA board for putting this together and just making it all happen. I know a lot of work was put into this, so I want to say thank you to all of you. This is a full circle moment for me. As she said, I've been coming to these seminars as an IBCLC for over a decade. And to be standing here on the stage today, I'm very honored to be presenting in front of all of you today. I remember sitting in a session a few years ago with a colleague, one who's here today, several who are here today, and saying, I could do that. I could be up there speaking. You guys remember that? So now that it's manifested today, so I'm so happy and honored to be here. Thank you. Thank you. Awesome. So today I want to establish a sense of sisterhood among us, because although you're my colleagues, I like to think of you as my sisters, because we are all working in the same field for the same goal, for the same cause. We have shared experiences in this field, and so just for the purpose of my talk today, is it okay if I call you sisters? Okay? Thank you. Thank you so much. Okay, so today I'm going to be presenting on the village approach to lactation equity for BIPOC families. Okay, I'm curious to know if any of you have attended a talk like this. Okay, few of us. Okay, so maybe a little bit of new information for some of us, but I really want to invite you to interact with me today. This is going to be more conversational, and I want to invite you to do some problem solving with me today for both of my talks. Okay, just as sisters. Okay, so before I do that, I do want to tell you a little bit more about me. Some of you know me or have seen me around or familiar with me, but I do want to give you a bit of a breakdown of my personal and professional history, because it really speaks to what I'm going to be trying to convey to you today. Okay, so it's a little bit long, but bear with me. So I was born here in Dallas, Texas, 1985 at Parkland Hospital. How many of you work at Parkland? Okay, got a few Parkland nurses. I was just talking with Sarah last night, and I told her I was born at Parkland. She said, "What year?" Because I was here. I said, "Did you deliver me?" I just missed her. She left a little bit before I was born, but I was born here at Parkland as a NICU baby, weighing 4 pounds, 11 ounces. Can you believe it? 4 pounds, 11 ounces. Can't believe it. So there's a lot that goes into that, right? 2000, kind of skipped ahead quite a bit here, but 2001 was my first doula and birth experience with the birth of my niece. And at that time, I didn't really know what a doula was, obviously. I think I was around 15 years old. But my sister-in-law had gotten pregnant with my brother's first child, and my mom asked her to move in with us so that we could just take care of her and keep an eye on the pregnancy and things like that and support her. Well, I just got really close to her, and we bonded during the pregnancy. So of course, when the baby was born, I wanted to be there. And I was there, and I saw the whole birth, the labor, everything. And I pretty much doulaed her throughout her pregnancy, labor, birth, everything. Not really knowing what I was doing. It was just a natural instinct. So that's kind of how I got infected with the desire and passion for birth work, starting with the birth of my niece, who just had her own baby this year. She's 23 years old. And I should include some pictures of my cute little niece. They came and stayed with me last week. I think now I know how grandmothers feel. Because, yeah, I was all over that baby. But that's kind of where this all started for me. 2003 to 2004. I was a little nerdy, so I had completed all my high school coursework by senior year. I had taken AP classes. So they really didn't know what to do with me, but there was this executive assistant program where you could get college credit for being an intern. So I actually ended up being an OB chaperone intern at Parkland Hospital. And I was able to go in different rooms in the OB departments. Parkland has a lot of OB departments. There's OB-ICC, there's OB-ICU, there's OB. I was able to, at that time, they wanted to have a female chaperone if it was a male doctor. And so I was able to just go in and chaperone and observe so many things. I got to see pap smears and cervical exams and all kinds of things. And then, of course, I was able to sneak into some of the labor and delivery sections because, of course, that's what I was interested in. So I was able to see hundreds of births over at Parkland during that time. And so that just further, ignited my passion for birth work. So while I was at my niece's birth, as well as while I was at Parkland, I always harassed all of the doctors. Like, I want to be like you when I grow up. What do I have to do? What do I have to do? What do I have to do? So they would always say, major in biology, major in chemistry, go to pre-med, right? Because I thought I wanted to be an OBGYN. After attending my niece's birth, I was like, I've got to do this. I love the whole birth process. So I did what they said. I went to TWU and Denton, majored in biology pre-med with a minor in Spanish and women's studies at Texas Women's University, 2004 to 2008. Well, let's see. In 2008, a little bit, before that, actually in 2007, I was pregnant with my own daughter, and it was my junior year at TWU. And I happened to have taken a women's studies course that took us on a field trip to Inanna Birth and Women's Care. How many of you are familiar with Inanna? Awesome. So that's where I had my baby. But we just went on a field trip there, and I didn't know about midwives and birthing centers at that time. You hear about be a doctor, be a lawyer, be a nurse. I didn't know about midwives and birthing centers, but I was always naturally holistic because I was partially raised by my grandmother. And if any of you been around your grandmothers, they have all these special teas and herbs and things that they use. So that was kind of natural for me when I saw that. It was very appealing, and I wanted to be a part of it. So little did I know at the time that I was going to be pregnant myself that next year after the field trip. Ended up having an unmedicated natural birth with my daughter, Amaria, at Inanna Birth and Women's Care. I was able to breastfeed her successfully for 13 months. While working, at that time, I started working as a birth assistant and a doula and a WIC care counselor, and was still in school and was able to come and breastfeed her. So in 2009, I graduated from TWU with a BS in biology and helped to establish a lactation room and space at the student union at Texas Women's University in Denton. From 2008 to 2011, I helped to establish the Denton County WIC Peer Counselor Program in Denton, Texas, as one of the first peer counselors in Denton. The only peer counselor of color at the time. I then certified as a Lamaze educator, a donut doula, and worked as a peer counselor, Lamaze educator, and donut doula. In 2012 is when I officially certified as an international board certified lactation consultant, and it was not easy. So yes, if you didn't know, I did start off as a WIC peer counselor, but it was a very unique experience for me. I worked at WIC, there's a little bit of gap there, so 2008, 2011, 2012, and all those years is the time that it took for me to get my hours needed to become an IBCLC. And I had to go to different states, different cities, to find mentors and to find hours. It was very difficult, but it has served as a source of my skill set and strength as an IBCLC today, so I am appreciative of that. Okay, a little bit more. So 2012 to 2014, instead of going to med school, I decided to go to nursing school and switch my career thoughts from by being a doctor or OBGYN to becoming a certified nurse midwife is what I had planned to do. So I went to Baylor, Louise Harrington School of Nursing. Although I had completed my biology pre-med degree at TWU, I took nursing prereqs while I was finishing that degree. And when I graduated, I went to nursing school. So it's actually an IBCLC before I became a nurse, which is also kind of interesting. 2012 to 2014, I worked as a birth assistant at Anana and a lactation assistant at Simply Moms at Baylor. 2014, I obtained my BSN, registered nursing license. 2014 to 2016, I did work at various local hospitals in labor and delivery, postpartum, mother, baby, and lactation. I helped to coordinate the lactation program at Las Colinas Medical Center. That was during year 2014 to 2016. Anybody here was at Las Colinas during that time?
I was there right after.
Right after, okay, awesome. Any of you still there? Okay, just curious. 2018 through 2024, I worked as a nurse home visitor with the Nurse Family Partnership at Wings, now formerly Ascend Dallas. Anybody familiar with that program? Okay, yeah, okay. Yeah, so I have some colleagues from there who are sitting in the audience today. So I was able to serve families kind of in a public health community sense in this position, but I was still working on the side doing private lactation consultations. 2015 to current, Mother Eve's Childbearing Support Services, LLC, is my private practice. We provide childbirth education, doula services, and lactation care. Also launching a mentoring and training for doulas and aspiring IBCLCs, which I'm very proud of. So, thank you. So yes, I wanted to develop a mentoring program because I had such a difficult experience to make it easier for aspiring IBCLCs to find mentorship. Okay, so there's a little bit about me. Now I want to know a little bit more about who's in the room. So I know majority of us are lactation consultants, but I'm curious to know who else we have in the room. What other professions, providers do we have in the room today?
Nurses.
Nurses, okay.
All the nurses stand up.
Don't be shy, don't be shy. Okay.
You ready for the camera? Okay.
Awesome.
Love it, love it.
Thank you for coming today. Yes.
Several people are IBCLC with another credential.
Right, okay. Anybody else care to share other professions? I know you.
Hi, I'm an occupational therapist and IBCLC.
Isn't that cool? Marissa spoke a couple of years ago. I hope y'all got in on that treat.
There's some dietitians in the room.
Nice.
Dietitians, can we see y'all?
Oh yes.
Dietitians.
Eating is important. Yay! Okay, awesome. Thank you so much for sharing. So I will get into the presentation objectives for today. So I want to talk to you about understanding lactation equity and bring awareness to lactation equity and explain its importance in addressing disparities among BIPOC families. Also want to describe my village approach to lactation equity. Apply this approach through problem solving. So I'm hoping you'll help me with problem solving today. Identify barriers. So we'll want to recognize some historical, cultural, and systemic barriers impacting breastfeeding initiation and duration in Black, Indigenous, and communities of color. Analyze IBCLC contributions and develop some strategies to help us combat some of the barriers that we're seeing in our practices. So I want to propose some strategies to advance lactation equity through community investment, interdisciplinary collaboration, and inclusive workforce development, which AKA sisterhood, right? So moving on, I want to just make sure we're on the same page for the terminology for today's presentation. So I want to define for you the village as it relates to today's presentation. It's a community of people who collaborate to provide comprehensive support and resources, equity, fairness, and justice in how resources, opportunities, and support are distributed to address historic disparities, BIPOC, Black, Indigenous, and people of color, acknowledging the unique experiences of different racial ethnic groups, and perinatal, the period of time from conception to 1 year after giving birth. Okay, so want to zone in on the lactation equity definition just a little bit further. So the term equity in and of itself refers to fairness and justice and is distinguished from equality. Whereas equality means providing the same to all, equity means recognizing that we do not all start from the same place and must acknowledge and make adjustments to imbalances. Okay, so why does this matter? We're seeing some breastfeeding disparities and systemic barriers in BIPOC communities. We see the evidence of predatory marketing of breast milk substitutes in the communities, inadequate access to quality lactation support, and insufficient policies to address social determinants of health. Does any of this sound familiar? Yeah. So the work involved in this movement confronts systemic oppression that has created barriers to successful breastfeeding for African American women, including some of these barriers that we've mentioned here. So this work is professional work for me, but it's also deeply personal because as a Black mom myself, I've experienced some of the gaps in our healthcare system. So I want to share some of that with you today. But before I do that, I would love to know a little bit more about your experiences in your workplace, just to give me an idea of what you're seeing versus what I've kind of researched. So please raise your hand and just help me kind of work through this. What disparities, if you work in a hospital setting, what disparities might you be seeing in your setting?
Lack of breast pump equals, so not easily accessible breast pumps. If you don't have it already at home from insurance, or you're barely requesting it when you give birth, breast pump, lack of breast pump access is a problem.
Access.
Yeah.
Access in general
Yeah.
is a problem, right?
Access for anything.
Yeah.
Absolutely.
Yeah, for sure. Yes.
Staff assumptions that you're not interested.
Say that again.
Staff assumptions that you're not interested.
That's a big one. I'm going to talk about that in my second talk today. Thank you. Any others? Yes.
Health literacy, that we don't lower the register to teach our moms and our patients,
Yes.
and taking in consideration what they understand and what is their health literacy.
Absolutely. Because we can go in and provide education, but how much of that did they understand, comprehend, and retain? Right? Is there a system in place to check what was the patient's actual comprehension of what they were taught? Like that. Any others? Ooh, yeah, okay. Amanda?
Underuse of the language line by staff.
So that kind of goes, yeah, for sure. So things get lost in translation. And they're going home confused. Yeah. Yes.
You could, go along that, like providing material that they can go home with that message, so like, we can translate right then.
Mm-hmm.
But what about when they go home and say, oh, I forgot what they said? We don't have enough material that is in their language or a way.
Yes, and for them to just, reference it and process it, because at that time of like discharge or being in the hospital, they're just in a different state and may not remember everything that they were taught, or even things that were given to them. So, awesome. Crystal?
The family connection of it all. I know that's what support of the family, especially in the Black community, they're like just breastfeed.
Yes.
So it's like the mother comes support, like, oh, you're feeding the baby again?
Yeah.
No formula. It's
Yeah, we're gonna talk about that today. Thank you so much. Anyone, private practice settings, challenges for this?
That continuity of care.
Oh, yes. Yes, there's a disconnect.
Yeah, and people go home and they're like, I didn't even know you existed.
Mm-hmm. I'm seeing that a lot. Too, thank you.
Sort of on the same line, the continuity of care for moms specifically when it comes to not the lactation aspect of it, but also just like why are they only seeing an OB 6 weeks later?
There's a big gap in the touch points of care.
Exactly. Also
Yeah.
for mental health, right?
Mm-hmm.
Yeah, just all
Yeah.
aspects.
Especially that we know that women are at higher risk for depression, postpartum depression in those first 6 weeks. Okay. Oh, yes, that's the core of my presentation today. You want to come up here and teach it? Tiffany? Or, yeah. Okay, let me get her, then I'll get you. Do you have a question?
Yeah, I would say it's a lack of ability to pay or the financial resources to get coverage for outpatient visits.
Yeah, for private lactation care, which is so much needed, right? Yeah. Tiffany?
I would say language in the sense of a little bit different of how you speak and making sure that they feel involved in the care and that they're not being talking over, but there are two that they're actually being involved in the plan of care. And then they don't feel like someone doesn't understand what they may be having going on in their house as far as lack of support, that all those things are considered whenever the care is being rendered.
Absolutely, man. Those are some good barriers as far as what we're able to see in our communities and our practice setting. Thank you so much for sharing. So I want to take a look at the data because the data represents these barriers that we're seeing. So these are the Healthy People 2020 breastfeeding goals. I provided a outline for you, or a blueprint rather, that will have all these things listed as well. So we're just going to talk about a few of these. So we see ever breastfed, 81.9% target, baseline 74%. Breastfeeding at 6 months, we have 60.6%, baseline 43.5%. And then let's look at exclusive breastfeeding through 3 months, which our target is 46.2, baseline 33.6. So I just want to look at a few of those for now. This is the Healthy People 2020. Now we're going to zone in on what's going on with our BIPOC families, so based on race and ethnicity. So if we look, we're going to look again at ever breastfed, 6 months, exclusive, and exclusive at 3 months. So we see for non-Hispanic whites, we're at 85.9%. At ever breastfed, 57.8% for 6 months, exclusive. At 3 months, we're at 44.5%. Non-Hispanic Black, so we can already see a pretty significant shift in the statistics there. Ever breastfed, 73.7%. At 6 months, 44.7%. And exclusive at 3 months, 35%. For our Hispanic families, we're at 84.1% for ever breastfed, 53.7% for 6 months, and 43.1% exclusive at 3 months. So as we can see, our BIPOC communities consistently fell below the national targets. And here are some key highlights. Black families have the lowest rate of breastfeeding initiation and continuation, highlighting the need for culturally aligned lactation support and systemic change. So somewhere along the way, we are missing the mark, right? We're missing the mark. Okay. So how do we know we're missing the mark? Let's look at the Healthy People 2030 breastfeeding goals. These are the targets that we're looking for. Okay. So we want to reach 84% for ever breastfed. And this doesn't break down ethnicity. This is the goal as a whole, right? And then breastfeeding at 6 months, 60%. Breastfeeding at 1 year, 34.2%. Exclusive breastfeeding through 6 months, 42.4%. So we saw 2020, now we're looking at 2030. That's a 10-year span, and we're still missing the mark, right? So how do we get here? How do we get here? Okay, so I want to talk to you a little bit about that. So in my research, this is what I have found to be helpful in strategizing and problem solving some solutions for us to help our BIPOC families. So I'll be speaking to you from the Saving Tomorrow Today, an African American breastfeeding blueprint. So you have this blueprint in your files here. So fortunately, there's been a lot of groundbreaking resources in the BIPOC community. This resource came from Rose, reaching our sisters everywhere, right? So again, that's why I'm calling you my sisters today, because we're standing together to reach those goals and to reach the target for all families. So this blueprint was developed by Rose, and it does address African American breastfeeding trends, systemic barriers, and community solutions. It combines the PROMS data from 2009 to 2015 and centers community voices through focus groups, interviews, and listening sessions. So this does provide evidence-based policy recommendations. All right, so let's look at specific African American breastfeeding data. There's been some progress, but there's still some gaps, okay? So the good news is that breastfeeding is on the rise. Are y'all seeing that too?
Yeah.
Yeah. It's on the rise for everybody. But among infants born from 2009 to 2015, there has been a steady increase in breastfeeding rates across all indicators for African American mothers. However, these rates are still below the overall national rates. Okay, so as you can see here. So then we have a little breakdown of regional and socioeconomic disparities, which some of you mentioned a little bit earlier today. So we can see that there's a large difference that exists among low-income women between African American women and other racial groups. So there's some studies, which you'll see here, that kind of zone in on focusing on certain zip codes where there may be more low-income families. We see that there's a minimal difference that exists for high-income women across racial ethnic groups. So that may be due to access, like some of you mentioned. With nearly 66% of African American women classified as low income, this is a critical group to focus on. As education increases, the gap in breastfeeding rates narrows between African American women and all women. So we're going to dive into that a little bit deeper. So I want you to be thinking about how can we effectively bridge that gap. So let's look at some challenges, breastfeeding duration challenges, period, across the board, right? So let's look at the first 4 weeks. Even within 4 weeks, differences in breastfeeding across race vary, but many women of all races who initiated breastfeeding have already stopped in the first 4 weeks. In the first 5 weeks, this is the first critical period when breastfeeding rates significantly decrease. And then 8 to 9 weeks, another large drop occurs between 8 and 9 weeks postpartum. And then again at 12 weeks, regional discrepancies among African Americans persist through the first 3 months of breastfeeding. That could be due to some maternity leave policies, may likely have a significant influence on these specific time periods. What are some reasons that you know of or that your clients have told you for discontinuing breastfeeding, just across the board?
Pain.
Pain? Yep, that definitely is like number one, right? What else?
Returning to work.
Returning to work, yep, talked about that. Mm-hmm. Infant sleep? Infant sleep?
Yeah.
Okay, good one. And then back here?
Supply.
Supply? Yes, like, and then sometimes it's a perception thing with supply, right? back there?
Not having the support at home or at work.
Yes, lack of support, that's a big one. So that is where we step in, right? Okay. So, you got it, right? Top reason for discontinuing breastfeeding, perceived insufficient milk supply. And this kind of goes back to what Jeanette was saying, especially if they're pumping and not using the right gland sizes. That needs to be assessed because that can affect how much milk they perceive they're making. Or, like she demonstrated, we have these 5 8-ounce bottles and we've got 2 ounces at the bottom, which doesn't look like a whole lot. Infant difficulty, which I think is that Laura back there mentioned infant sleep, pain and discomfort, return to work. So you guys hit it on the nail. Yeah. Okay. Okay, good. So we're all on the same page with that. Let's talk about a little bit of a different factor, stress and discrimination, the impact of stress and discrimination, which I could imagine not having support at home would cause a lot of stress, right? So African American women face statistically significantly higher, ooh, that's a tongue twister, stress levels and racial discrimination than non-Black women. Stress is associated with a shorter duration of any and exclusive breastfeeding. Nearly 10% of African American women reported being upset by racial discrimination within 12 months of birth. These factors must be addressed as part of comprehensive breastfeeding support. Have any of you heard of this from any of your clients, any BIPOC families that you've worked with?
Yeah.
Yeah? Okay. What are your thoughts on this?
There's 2 aspects I think that come along with the stress factor, and I only speak for the Hispanic area that I grew up in. I think that it's not just the outside factor of the professionals, healthcare professionals, the support that they receive, right? Those resources available for them, where it's you're trying to do something, but there's no support in that aspect, right?
Right.
But also, coming from a Mexican American family, there's a lot of times in households, multiple generations there, right? And so it's not just like, okay, we'll go home and with your partner and your new baby, you also have opinions and experiences from your mom, maybe your grandma also, on
Boy, do we know.
maybe getting there or going there on a frequent basis. And so you then feel that added stress of
Yes.
like trying to be respectful, the pressure, right? The mental health aspect of that, right? And so it's really on the inside of the home, but also on the outside.
Absolutely. So sometimes the support they have can be an added stress factor. Yeah. Thank you for sharing. So I want to kind of think about how did we get here? I'm all about the root cause. So how did we get here to these statistics that we're looking at today? And what the research shows is systemic racism, historical trauma, the lack of culturally competent care, including accessing proper language lines, including making sure the comprehension is understood when educating, access, we talked about that, medical distrust is a big one, especially in our communities. If you know a little bit about history of medical practice in BIPOC communities, you'll understand that there can definitely be some medical distrust. We talked a little bit about formula marketing in communities of color and generational breastfeeding gaps. What additional barriers do you observe in your practice? And this is more so for you. What's a barrier for you in your practice that you're seeing? So workplace setting, staffing limitations, cultural barriers, language access, in the community, resource disparities, transportation challenges, and housing instability. For education, provider knowledge gaps. Do you feel 100%, what's the word I'm looking for? Confident in knowing how to support a BIPOC family or a BIPOC mom. So think about that. And then what can we do to help you feel more comfortable with that? We have family information access and cultural awareness, policies, insurance coverage gaps, which is a big deal right now due to some recent changes, parental leave limitation, and workplace accommodations. So there's not only barriers for these families, but there's some barriers for us too, as providers, as lactation consultants, as nurses, in helping them to combat some of these barriers. So what can we do about it? So I'm going to show you today some programs and incentives that can help address some of these barriers. And then again, the focus on zip code for low-income families. Any of you work in low-income areas specifically? Okay, good. So there's some programs and incentives that focus on training breastfeeding support providers of color. We need more IBCLCs of color, more CLCs of color, more providers of color in training them and educating them. Implement more community-centered mother-to-mother support, like the support groups, breastfeeding support groups. Establish fatherhood engagement and initiatives. This is really, really important. So if you look at the research, it says one of the single most important factors in a woman's breastfeeding success is the involvement of the father and the support of the father. Did y'all know that? I can see that in my practice. I see a big difference in my families where the dads are involved, especially when I come over for a lactation visit and I'm like, here daddy, try this, put this, do some compressions, wake the baby up. And they're so involved, and I have other daddies who's like, I'm gonna go watch the game while y'all do this, Those moms do, in my observation, tend to struggle a bit more without that support. So for policy, we want to support federal policies like the Supporting Working Moms Act, since we know that that's a challenge and barrier to continuing breastfeeding. Increase access to lactation providers of color, improve child care and workplace breastfeeding policies. The data shows that we should collect zip code level breastfeeding data, track number, type, and race ethnicity of support providers, and implement comprehensive data collection systems. So here is another way of looking at how do we get here, where do we begin. So earlier I talked to you a little bit about lactation equity, and we talked about how we don't all start from the same place, right? So as BIPOC families, where did we start from? Where did we begin, right? So I think this is important to implement into our practice and our care for BIPOC families. So I want to talk to you a little bit about our roots, okay? So we know that breastfeeding is deeply, deeply rooted in African culture, traditions, not only as a vital source of nutrition, but as a sacred bond between mother and child. It's historically passed down through the maternal line. Breastfeeding and wisdom was shared by elders, aunties, and midwives. In many African communities, extended breastfeeding lasting 2 to 3 years or more was the norm, reflecting the value placed on nurturing and continuity. So this is culturally our roots in Africa and how breastfeeding is represented in that culture and the impact of breastfeeding in that culture. So this is kind of where things started. Now we're going to kind of go back to how do we get here. So going back into African tradition, we want to see that the cultural significance of breastfeeding in Africa has always been the ancestral norm across the African continent. However, during slavery, African American women often had to forego breastfeeding their own babies while being forced to serve as wet nurses. So this definitely made an impact from moving from Africa to America. One of the things that I see in the African culture of breastfeeding is community and breastfeeding. And one of you mentioned that today. And it's a shared experience of raising babies together, right? You'll see just like the picture, you'll see women just lined up outside, breastfeeding their babies together, just like it's a normal day. It's the norm. It's a sense of individual and familiar pride. Breastfeeding as a communal responsibility. It's this responsibility of the community to ensure that the baby is breastfed well. Culturally determined behavior, the importance of the breastfeeding role model, that's so big, the breastfeeding role model. So I just had a baby. If my mom breastfed and my auntie breastfed and my grandma breastfed and my sister breastfed, I don't know that we would have an IBCLC job over there. I don't know. Because everybody, has breastfed and they're just kind of passing it down traditionally, generation after generation. So there's that significance and importance of kinship. So some other cultural and traditional things that we're seeing in Africa. We talked about extended breastfeeding. It's a big deal. So I found this to be really interesting how when we looked at the rates earlier, we can't even make it past 4 weeks, 6 weeks, 12 weeks, 3 months, 6 months. But here in Africa, women are breastfeeding 2 to 3 years. That's the norm. So breast milk has its spiritual healing and power in the culture. And it also is seen as a blessing workers that can transmit life and heal illness. It increased immunity to disease, reducing the risk of chronic conditions like obesity and type 2 diabetes, and reduction in the risk of ear infections. Okay, so I want to take a look at African American women and kind of compare African women and African American women as far as the challenges of breastfeeding. There's some research that shows that African women, with these traditions that we just went over, when they cross over and come to America for whatever reason, maybe they're visiting or maybe they are having a baby here or whatever, things change. Things change from what they're used to. And formula is like, oh my gosh, I gotta get my hands on that, that's the good stuff. They've been told and marketed that that's better than breast milk. And so things change when they come here because of some of those barriers that we mentioned earlier. Okay, so here are some breastfeeding challenges and obstacles among African women. Sometimes colostrum can be seen as dirty. Have y'all heard that one? Yeah, heard that across several different cultures. So that's an interesting one. So we combat that with what? Education, right? Belief that babies need water or herbal tea. Y'all heard that one? Okay. Importance of education that's culturally humble and not dismissive. So when we do hear something like that, a client tells us that they think the colostrum is dirty, be careful with your response, right? You don't say, oh my God, that's not true, or how could you think that? But just be very humble with the approach. Why do you think that? Why do you see it as dirty? And try to get an understanding of why they think that, so that you can help them navigate to the education of the actual truth and benefits of colostrum. So some African immigrants in Western countries often reduce breastfeeding length. Again, once they make it here. Public breastfeeding norms influence behavior, the need to normalize breastfeeding, and then again, the perceived inadequacy of milk production. Any of this sound familiar? Yeah, okay. And then here's some breastfeeding challenges and obstacles of African American women. Number 1, perceived insufficient milk. Many women stop because they believe they aren't producing enough, infant difficulty, pain and discomfort, and return to work and school. So the challenges are, some of them are similar, some of them are a bit different. So I want to talk to you about the village. you guys have heard the term, it takes a village, right? So tell me, what does that mean to you? So a few people, tell me what that means to you, it takes a village. Community, absolutely. What else?
Can't do it alone.
Support, and I heard something over here.
We can't do it alone.
Can't do it alone. Amen. Okay, so it really takes a village to raise a child. This is an African proverb, and this wisdom reminds us that child rearing, and by extension breastfeeding support, is a collective responsibility. It emphasizes community over isolation, involves elders, extended family, neighbors, and professionals, fosters holistic development, social, emotional, educational and physical, and aligns with the village approach to perinatal and lactation care. So, have any of you, I know our sister here mentioned some challenges with being working with some Indian clients. Have any of you ever been in the home of an Indian client or an African client for a lactation visit? It's a different experience, isn't it? It's different. So, like she mentioned, our sister here, that in an Indian home, a lot of times the mom is present. She may come over from India, and then for 3 months, and then sometimes the mother-in-law is also present. They are cooking, they're putting together herbs and spices and nutrition for the postpartum recovery and the breast milk production. And they're kind of like, we call them princesses, right? Like they really get well taken care of, and I love it. And I wish that all of our families could have that type of support in some capacity. Also, as a lactation consultant, you are not leaving that home without food and something to drink.
That's right.
And you better not say no. You better take it and pretend we ate it. So it's even you get taken care of when you come over here. Like no one is stepping in that household without being cared for, right? So if we could all just adopt that mentality and that community and that mindset as we're caring for our patients, it really makes a difference. So that is what the village is all about. Yeah.
The only thing I don't like about that, and I love what Indian moms, is the fact that they all believe and they say it all the time, well, we use formula to ensure good nutrition. And I'm just like, that just sets my teeth on edge.
Yeah, and some of my...
Try to unwind it.
Mm-hmm.
So, and they don't think it's any big deal to do 2 or 3 formula bottles in the middle of the night so the mom can sleep through the night. And they'll go, plus it ensures good nutrition. And you're just like,
It is simply an adaptation to the culture here. They're not doing that at home.
I'm never gonna do that at home.
The comment I was going to make during the earlier discussion,
Mhm.
I work in a hospital setting at the bedside, and one of the challenges, it's not all of them, but it's so many, is that the moms will not lift their arms to even hold the babies. And so I usually will say, when I'm not get latches, like I don't know if that's going to take this particular situation, I'm going to have your hands take over for me. And they look at me like I am from Mars, and the mother-in-law and mom are talking over me on the couch far away, so they're not hearing any of what I'm saying, and the dad is completely disengaged. So I'm in the room like, who here is in a learning mode? Because I can't go home with you, and someone's going to need to be able to have this baby not slide right on his mom onto the floor. And I feel like that's what's going to happen. So like I feel like I've derailed the conversation. I didn't mean to.
No, that's a part of it. It's great that they have that type of support, but it's also, it can affect their independence when it comes to breastfeeding, right? So that's another challenge that we kind of have to navigate around.
My experience, I worked in Northern Virginia for about 8 years and did have quite a few families who had recently arrived from Africa, and I remember that I had a mom that called out to the emergency station with a 9th baby having hormone, and she exclusively breastfed their kids. So I went to talk to her and I was like, what?
Yeah.
And so what I really learned from her is the insecurities that many of our moms have about making enough milk, they had at home. They just didn't have access to formula.
Exactly.
It's like, if she would have had it, she would have used it at home. It wasn't that she felt so much better and more empowered and better about her supply there than she did here. She just didn't have a choice, so she fought through it, and it all worked out for her. But when she got here, she was like, this is the it's just what I'm used into. So, they have the same insecurities that we do.
Absolutely. Good point. Thank you for sharing. Okay, I got 10 minutes, y'all. I do want to share real quick an experience that I had at NSP. When I first joined in, you have to go through some training and some precepting, right? You do nurse home visits. You are dealing with pregnant women in some of those zip codes with lower income families. Most of the moms in this program have Medicaid or WIC, and they're able to obtain a kind of a private nurse to kind of help support them throughout their pregnancy, from the second trimester all the way up until the child is 2 years old. So I went through some training starting off, and the nurse that trained me was a white nurse, and I followed her, and she went into an African home for one of our visits, and she had been seeing them for months. Like, the baby was, I think, 9 or 10 months, and she was talking to them and all these things, and I was just sitting there bystanding because I'm learning, I'm training, right? And the family was not looking at her. She's teaching them, but they're looking at me, and the questions that she's asking them, she's responding to me. And I'm just in the background like, But that told me something. That was a message, right? There's a connection there because you look like me. And even though she had been with them for 9 months, I feel more comfortable with, and they gave me a Sprite. And when we left, she was like, they never give me it. So it just, it said something. So that was an interesting experience for me as I was starting out nurse home visiting. So I want us to basically focus on wraparound care for the family. So I'm going to show you this little video with these elephants. As you can see, there's a little bit of an earthquake going on here. See the ground shaking? So just kind of watch what happens. Y'all see the baby elephant in the middle? I think y'all get it. I'm running out of time, but y'all get the picture, right? So these elephants are just hanging out, normal day, hanging around, drinking water, grazing, and all of a sudden the ground starts shaking. And their instincts told them to wrap around the baby elephant. They didn't know what was going on, what was going to happen, what was about to happen. They just wrapped around that baby. And so that's kind of what we have to do for our babies, right? We have to wrap around our mamas and wrap around our babies to ensure their overall safety, right? Okay. Let's see if we can get this presentation back up. And we're almost done. Okay, so I'm proposing to you that we become the village for these families. Collective support before, during, and after birth, incorporating doulas, peer counselors, public health workers, lactation professionals, and just filling in the gaps of the hospital and community care. Earlier, we talked about that disconnect from hospital to community. So how can we fill in those gaps? So our core members of the village, we know that doulas provide emotional and physical support, birth planning, and postpartum care. Peer counselors are relatable, shared lived experiences, IBCLCs, the clinical lactation expertise, and the CHW, community health worker, connection to community services. So the reason I shared my outline with you because I've done all of these before. And it's been me connecting and moving and connecting. I'm the doula, I'm birth planning, I've done all of this, even at NFP as a community health worker. I can't do it alone, right? So, and as lactation consultants, especially if you work in a hospital setting, which I remember some constraints and limitations from that. Sometimes there's only so much we can do. So we just need to grab those people that are in the community to help us with this mission. Okay, so there's some roles of everybody has a role, right? Role of the IBCLC in hospital settings. We talk about points of contact here. I'm going to talk a lot about this in my next talk this afternoon. So I'm just going to go through this, but you'll hear more about it in the next talk. And so in your package, you also have some recommendations, programs, and initiatives that have been established specifically for BIPOC families. I mean, there's lots of resources now, more than what I had before at the beginning of my journey. So these you have access to. Okay, lots of resources. All right, we made it.